Welcome to my podcast. Today I'm going to talk about another common case, which basically can appear in BLAB 2 examination. So basically, you after you introduce yourself, as we always agree, double check the patient name, date of birth. You will ask the patient whether it's a male or female. How can I help you today? So the patient might be a man or an elderly woman or elderly man or any age group, basically, which is mostly in their maybe 40 or late 40 or start of 50. So this kind of age group. So the patient might say, I'm having issue which is very embarrassing and it's causing me too much, it's just bothering me and impacting my life. And it's basically about involuntary loss of urine, and it doesn't make sense to me. It just make me feel embarrassed, and I withdraw from the social engagement or social connection, and I just want a solution. So you'll ask the patient, how did it all start? Since when? Is there anything that increase it or decrease it? Have you done anything? What makes it worse? Is there any association with anything that you might think that it has caused the issue? So the patient might say, I'm having this urinary leakage since some time, maybe after I had birth, or maybe when I hit, for instance, the menopause, or a man in man condition might say that he had an operation for the prostate, and after then he had those kind of symptoms, and it's just annoying because he can't hold his urine, and he feels that it's always leaking and just wetting him or her pant and underwear and always smelly, stuff like that. So just patient needs solution. So I need to ask what makes it worse. For instance, it might say when I cough, I get that. If I strain, if I have constipation, if I want to strain, for instance, or if I'm going to the gym, lift some weight, or I'm jumping, or exerting some effort, or running, straining, all of that, increase it. And you'll ask about certain questions just to exclude if there is any overactive bladder, which is called urge incontinence. So, for instance, you'll ask, can you hold the urine? Do you feel the urge that you can't hold it? Do you pass it without your control, effortless? How frequent do you need to go for voiding? And what about nocturia? If it's too often at night that you need to visit the loo to pass the urine, what's your drinking like? Those kind of things. You need to ask about caffeine as well, alcohol, smoking, if there is any relevant past medical history, as I say, birth or radical excision of the prostate, and what sort of operation the patient has undergone. And also, you'll ask about medication-wise. If there is any medication that you think could be relevant, you need to ask, inquire if he had received any medication, and if there is any family history of relevant history, and also, of course, about the lifestyle and the work thing and whom they live with. All of that you just need to touch upon while you are taking the history. And then you will ask the patient, I would love to have a quick look if that's okay with you. I will have a chaperone for your dignity and privacy. And then you will, of course, after examining the observation, the main observation, you just check if there is anything that's relevant externally. And then you will perform a pelvic examination just to exclude if there is anything relevant, say for instance in the woman condition. You will examine the vagina, see if there is any atrophy, or laxity, or if postmenopausal atrophy. And you will ask if there is any dryness, and if the woman is sexually active, you will ask about the coitus if it's causing any issue. Sometimes the patient must say dryness causes too much irritation. And you will ask the patient while she's in her lototomy position, ask her to cough, and while you're examining, do Valsalva maneuver just to see if there is any urine dripped out of the urethra while doing so. And then you will ask that the patient, you're going to examine her pelvic floor tone by vaginal palpation, and using the modified Oxford grading system, which ranges from 0 to 5. 0, there is no contractility at all, and 5, it means it's good, and the range between 1 to 3, it's starting from flickering to weak to moderate tone, pelvic tone. And then you will check also for the prolapse. Certain women after multiple pregnancy and birth, they might have prolapse. So but this needs to be done by SIM speculation. So I need to examine by SIM speculation and see if there is anything in the wall of the vagina. Say, for instance, you will examine the lateral wall, you will examine the anterior wall. You will examine also if there is any something like projected or it's always like the wall is projecting a little bit, so it's called, if it's anterior, it's called cystocele. If it's in the posterior part of the wall, the vaginal wall is called rectocele, and sidewise you will examine as well. And don't forget to do your anal sphincter examination with a chaperone as well, just to examine if there is any neurological issue, or maybe there is spina bifida issue. So if there is any dimple or there is hair in the sacral area or the coccyx, and just warn the patient that you're gonna do the BR, just and ask her to, or ask him to hold tight the anal sphincter around your toe, around your finger. So basically, that's in regard for the examination, and then you will discuss with the patient what's the management moving forward. So always it's mandatory and advisable to start with non-invasive ways. So it's always about pelvic floor exercise as a first line, which has shown that 80% cure rate, and it's, as we know, always it's called Kegel. And it's basically to strengthen the pelvic floor and urinary resistance. It's mandatory to do like 8 repetitions 3 times a day for not less than 3 months. And preferably can be taught by the physiotherapist who is specialized in the pelvic health, and setting a target time for toilet use. And this is the way has been proven to be successful in 80% of the patient. The pharmacological intervention, like certain drugs like duloxetine, it has very limited evidence, and it's a poor option. However, it can cause relapse once it has been stopped, and also the side effect is not favorable. Like, for instance, the patient might complain of nausea, dizziness, constipation. Also, they might have issue with sleep, so they might have insomnia. And constipation, which of course will aggravate the condition, because basically if you need to strain, this will increase more the incontinence, so it's something that's not favorably. It has been before stated in the textbook that you can do something called urodynamic investigation. This procedure is basically invasive, whereby you need to introduce a tube to measure the pressure. However, nowadays it's not advised, and it has proven that it has no use at all, and it's advised not to do this anymore. Men-wise, it's mostly the reason for that is the patient mostly had prostate cancer, and they had a radical excision of the cancer. So in that condition, they have problems sometimes with the urine. They might have incontinence. So that's one of the issue. You need to discuss what sort of things that can be done, and both sides, in men and women, if the this one the non-operative, the first procedure, which is basically the pelvic floor strengthening, if it didn't work, so you need to discuss with the patient what sort of operation can be done. There's different ways how to tackle the issue, and it's tailored to each patient accordingly. So there might be a string, there might be different options that can be discussed with the patient and state the pros and cons in order for the patient to decide what's the best moving forward. Some time ago, there has been a thing that has been done to women, so it's called mesh correction. So it has proved nowadays it's not favorable as well. There is a lot of complication with that. And certain situation, it had extrusion and has been extruded in the tummy and caused perforation and caused recurrent UTI, and also imagine that it has been immigrated in the tummy, so it caused abdominal pain and voiding issue, so the patient have difficulty to void or could be exposed in the tummy. So this is one of the things which is not favorable as well and has proven that it's not the best choice to do in this condition. So that's just short about stress incontinence, how you can tackle it, how you can treat it, and how you can manage it in those kind of situation, and how you can see what's the reason, and if the patient have an idea or any thoughts what might be the cause, and in order to try to help the patient and improve the situation, and of course ask them to decrease weight and try to strengthening their pelvic floor, as I say, and minimize anything that cause increase in the intra-abdominal pressure on the in the chest as well, like cough, flu, stuff like that. Thank you.